Welcome. Today we're diving into eyelid reconstruction, absolutely vital for eye protection, function, and of course, aesthetics. We'll cover the core principles you need to know for tackling different kinds of tissue loss.
Absolutely. And you really can't tackle reconstruction without a solid handle on the anatomy. Um, think of the eyelid in layers, two main ones, really.
Okay.
You've got the outer layer, that's the skin, and the orbicularis muscle, the one that closes the eye, and then the inner layer.
The inner layer being.
That includes the tarsal plate, the stiff structural part, the canthal tendons holding the corners, the capsulopalpebral fascia below, and the conjunctiva, which is the lining.
Right. And sometimes people talk about a middle lamella too, the orbital septum.
Yes, sometimes that's considered separately. But fundamentally, it's about that anterior skin muscle layer and the posterior tarsus conjunctiva layer. Understanding that split is key.
Okay, got it. So let's start with partial thickness loss. What if it's just the skin that's missing? What are the main options?
Well, for just skin loss, you're generally looking at two main paths. Either primary closure, just stitching it up.
If it's small enough.
Exactly.
All right.
Or using a full-thickness skin graft. We often lean towards FTSGs, full-thickness skin grafts, because they tend to contract less down the line.
And where do you ideally source that graft from?
The best match, texture and thickness-wise, is usually the opposite upper eyelid. You get a really nice result.
Huh.
If that's not available, postauricular skin from behind the ear is a decent second choice.
And if you do go for primary closure, any pitfalls?
The big one is tension. You absolutely have to avoid tension. Pulling it too tight can cause ectropion, where the eyelid edge turns outwards. So low tension is crucial.
Okay. Now, what if the partial loss involves the inner lining, the conjunctiva?
For conjunctival defects, the ideal replacement is actually using adjacent conjunctiva. You can often create a sliding flap, advancing it over the defect.
Makes sense, using like for like.
Precisely. But if that's not feasible, maybe the defect's too big or the adjacent tissue isn't healthy, then you look at grafts.
What kind of grafts?
Mucous membrane grafts are the way to go, usually from the buccal mucosa inside the cheek or sometimes nasal mucosa.
Any difference between those two donor sites?
Yeah, there is.
Yeah.
Nasal mucosa seems to contract a bit less than buccal mucosa, which can be an advantage.
And skin grafts are a definite no-go here.
Absolutely contraindicated.
Right.
Skin on the inside, it would constantly irritate the cornea. Big problems.
Right.
And interestingly, even grafting conjunctiva itself isn't ideal. It tends to shrink quite significantly, so we generally try to avoid conjunctival grafts if other options exist.
Okay. What about the tarsus, that structural plate, if there's partial loss there?
You know, isolated partial loss of just the tarsus is actually pretty rare. Usually, if the tarsus is damaged, it's part of a bigger composite defect involving other layers too.
I see. But if it did happen, or as part of that composite loss, how do you address the tarsal component?
Options include direct repair if the edges are good, or using grafts. Things like palato-mucosal grafts, sometimes cartilage grafts, or even a cellular dermal matrix have been used to replace or support the tarsus.
Okay, that covers partial thickness. Let's shift to full thickness loss, specifically in the upper lid. When is simple direct closure still on the table?
For full thickness upper lid defects, you can often get away with direct closure if the defect is, say, up to about 25 or 30% of the lid width. In older patients, you might have a bit more inherent laxity in the tissues. So sometimes you can even push that up to maybe 40% closure directly.
And if it's a bit tight when you try to bring the edges together?
That's where a lateral canthotomy and cantholysis comes in handy. It's a release procedure at the outer corner.
Right, cutting the inferior crus of the lateral canthal tendon.
Exactly. That releases the lid laterally and gives you maybe another 10 to 15% of length, reducing the tension on your closure.
What's the most critical part of that direct closure?
Precise approximation of the tarsal plate. You need those cut edges of the tarsus lined up perfectly. That provides the structural integrity and, crucially, prevents a notch forming in the lid margin later on.
Very important point. Okay, what if the defect is bigger than what direct closure, even with cantholysis, can handle, say up to 60%?
Then you're moving into flap territory. For the upper lid, a very common and reliable technique is the tensile semicircular flap.
How does that work?
It essentially combines that lateral canthotomy and cantholysis we just talked about with a laterally based myocutaneous flap, so skin and muscle.
Okay.
You rotate that flap in to help close the defect. It's a workhorse flap for defects up to around, maybe 60% of the upper lid.
So stepping back a bit, thinking about all these techniques, what are the overriding principles we need to keep in mind for any eyelid reconstruction?
Well, number one is always a thorough assessment. You have to know exactly which structures are involved, skin, muscle, tarsus, conjunctiva, and critically, how much tissue is actually missing. Is it partial thickness, full thickness, and what percentage?
That assessment really dictates the approach.
Absolutely. The choice of technique hinges on whether it's partial or full thickness, and very importantly, the size, the percentage of the defect.
And in terms of materials.
Eyelid tissue itself is always the best option, if available. Like, replaces for the best aesthetic and functional match.
But you have to be careful, especially with the upper lid.
Exactly. You have
Yeah.
to be cautious about borrowing too much from the upper lid. It's so vital for protection, for corneal coverage. You don't want to compromise the donor site significantly.
Can we sort of summarize some rough guidelines based on defect size?
Yeah, we can give some general ranges, though obviously patient factors matter.
Yeah.
But roughly up to maybe 30% loss, you're often thinking primary closure.
Okay.
For 30 to 50%, direct closure, but usually adding that lateral canthotomy and cantholysis for release.
Right.
Getting larger, say 50 to maybe 75%, that's often where myocutaneous advancement flaps like the Tensile come into play.
And for the really large defects, over 75%.
For those major defects, you're typically looking at needing tissue from the opposite eyelid, perhaps with lid sharing procedures, or bringing in tissue from adjacent regions, like forehead flaps or cheek advancements, depending on upper or lower lid.
And one final point on technique.
Regardless of how you reconstruct it, whether it's direct closure or a flap, ensuring good fixation of the reconstructed lid is essential. Either secure canthal fixation at the corners or meticulous direct eyelid margin closure. That prevents postoperative issues like sagging or malposition.
So it really boils down to, first, deep anatomical understanding, and second, meticulous assessment of the defect size and layers involved.
That's it precisely. From there, you select from the available toolkit, direct closure, grafts, local flaps, tailoring it to that specific defect.
And always keeping in mind that delicate balance, right, between restoring function, protecting the globe, and achieving the best possible aesthetic outcome for the patient.
Exactly. It's a challenging but incredibly rewarding area of reconstruction, always aiming for that optimal blend of function and form.